Welcome to our module on limited obstetric ultrasound of the placenta and localizing a placenta. Our objectives of this module are to understand the relevance of identifying the placental location, the indications for this exam, how to perform this exam and interpret the findings, and how to manage the findings that you identify. As a disclaimer, there is a large amount of detail that can go into placental assessment, both with abdominal and vaginal probes. The scope of this module is to demonstrate how to perform a limited obstetrical ultrasound of the placenta in the midst of a point-of-care study, both for antenatal or intrapartum use. It's important to have an idea of where the placenta is located because placental location may significantly impact a patient's clinical course. Placental location will impact their potential route of delivery. So, for example, in the case of a marginal or complete placenta previa, there is a chance that a patient may require a cesarean delivery. Additionally, a marginal previa or complete placenta previa significantly impacts a patient's risk of having antenatal bleeding. Lastly, abnormal placentation can be identified prior to delivery and allow for appropriate operative planning and the appropriate clinical setting for delivery to minimize the potential morbidity associated with this condition. Placental location is considered a basic component of routine prenatal care and perinatal ultrasound. And basic prenatal ultrasound is an important skill for family medicine residents. In the Society for Teachers of Family Medicine consensus statement, prenatal ultrasound and localization of the placenta is considered a required skill to achieve by graduation. Now we're going to go over the appearance of a normal placenta. As you can see in this depiction on the right of a still ultrasound image, the placenta is an echogenic, homogeneous structure attached to the uterine wall. This is the placenta here. As you can see in this image, there are sharp demarcations on both sides of the placenta, maternal and fetal. On the fetal side, you should be able to see the interface of the placenta with amniotic fluid. Amniotic fluid is not echogenic in any capacity and is dark, so that makes that border very easy to discern. Additionally, on that side, you will see the fetus in the amniotic fluid. On the maternal side, you see a retroplacental clear space, which is the interface between the placenta and the myometrium of the uterus, which I am tracing here with the arrow. This space is relatively stable in width throughout the scope across the retroplacental interface. And this is a normal appearing echolucent space here. In localizing a placenta, the most important thing to do first is to identify the placental body and to identify the primary site of attachment. The placenta can be attached in any location on the uterus, fundally, anteriorly, posteriorly, or covering the cervical os, which is known as a placenta previa. The ultrasounds on the right, these still images, are going to depict those placental locations now. This is an example of a fundal placenta. While you cannot see the entire uterus in this view, this round portion on the left of this image represents the fundus, with the placenta attached right in the mid portion of the uterine fundus. This image depicts an anterior placenta. You can tell that this is anterior because this placenta is superficial relative to the ultrasound probe, which is attached here. This is the most deep portion. This is the most superficial portion, and therefore this is the anterior uterine wall. Here's an example of a posterior placenta, which is deep in the deep part of the uterus. So if your ultrasound probe is here, this is the most deep wall of the uterus, and the placenta is attached here. This is a posterior placenta. After identifying the placental body, you need to evaluate both in the sagittal and coronal planes to get an idea of the extent of the placenta and how far the margins of the placenta reach. So this is a nice example of a sagittal view, which gives you a nice picture of the extent of the placenta down to the edge or margin here. But while you're scanning, this is a still image, so while you're scanning in real time, you want to ensure that you're able to see the extent of the placenta in both planes. If the placenta extends into the lower uterine segment or approaches the cervix, that patient needs to be referred for a formal assessment with a transvaginal probe to ensure that to confirm the presence or absence of a placenta previa. A placenta previa is a placenta that covers the cervix either completely or partially. A placenta previa is also considered to be in place when a placenta extends close enough to the lower uterine segment and internal os to cause bleeding when the cervix dilates or the lower uterine segment effaces. This here is an example of a complete placenta previa, and what is outlined with the calipers is the cervical canal, and the placenta here extends completely over the internal os of the cervix, representing a complete placenta previa. A marginal previa is a placenta that has an edge that extends within 2.5 centimeters of the internal os of the cervix. This ultrasound picture depicts a marginal previa, and as you can see, the placenta here, labeled P, extends to the edge of the cervical canal, which is this echolucent space here. So if this is the internal os right where the arrow is, that placental edge is very close, if not overlying just a small portion of the internal os. Lastly, the term low-lying placenta is used to describe a placenta that has been identified on transabdominal ultrasound that may reach the internal os, but it cannot be confirmed without a transvaginal image. Additionally, this can be used to describe a placenta that extends into the lower uterine segment, but the precise limits are poorly defined on an abdominal ultrasound. Timing is important when assessing a placenta. The prevalence of placenta previa is much higher earlier in gestation. As pregnancy progresses and the lower uterine segment develops, many low-lying placentas or marginal placenta previas may resolve. Therefore, the incidence of placenta previa falls as you get close to term. The absolute incidence of previa is approximately 1 in 200 term gestations. Placenta previas that are identified early in gestation, as I mentioned, may resolve. So as you can see here in this graph on the right, which is a study of over 700 placentas, when they're diagnosed at 15 to 19 weeks, only 12% are present at delivery. The farther along you get in gestation, where previas are identified, the more likely they are to persist and be present at delivery. Therefore, when previas are suspected or diagnosed early in pregnancy, follow-up imaging is recommended. Generally, most patients are having ultrasounds in the mid-trimester between 18 and 22 weeks, where their placenta is being assessed, as well as their fetal anatomy. When previas are diagnosed at this time frame in pregnancy, a follow-up ultrasound is recommended at approximately 32 weeks to reassess the location of the placenta. Thank you for participating in this module. We hope that you are now able to assess and localize a placenta.